here. Now, branches of the spinal nerves, and it's probably easier to discuss it on this slide. So you guys, I want you to just kind of, stay here. We'll talk about the dorsal ramus and the ventral ramus, right? But it's easier if I describe it on the picture. So let's take a look. Spinal cord, right? Anterior horn of the spinal cord contains cell bodies for our motor neurons. Somatic motor neurons. Somatic meaning voluntary skeletal muscles. So when I want the biceps muscles to contract because I'm working out, what happens? Well, it starts off, let's say I'm doing bicep curls with my right arm. It starts off with the left hemisphere of the brain. That area, right? Remember, there's a crossing over. So that left area of my brain in the front region stimulates. There's a motor neuron up there that then comes down the brain, comes down the spinal cord and crosses over. As it crosses over, it synapses with cell bodies of our somatic motor neurons found in the anterior horn. Now, this second motor neuron is one that we've talked about. That's the one that exits out and releases acetylcholine onto our skeletal muscles. We've seen that, the end of it. The end of it was in the, was found in the neuromuscular junction. That's where the synapse was. Now we're going to talk about the rest of those motor neurons. In terms of the rest of the motor neurons, the cell bodies in the anterior horn, and then you have the axons that exit out through the ventral root. Again, how come there's no ventral root ganglia, no bump? There's no bump because there's no bump because the cell bodies are found in the anterior horn. So the cell bodies of the ventral root are found in the spinal cord. They're clustered as a nucleus inside the anterior horn. All we see of it are the axons that exits out right here. As the axons exits out, they form the ventral root. They also fuse with sensory signal coming in, those sensory neurons coming in. As they fuse with sensory signals coming in, they form the spinal nerve. Once we see them fuse right here, right, and we kind of mentioned, at this point, right, when you get closer to the spinal cord, we know all sensory information goes to the back. All motor information's in the front. But once we form the spinal nerve, everything gets mixed up. So if I cut the spinal nerve right here, and I look at the back of the spinal nerve, I will have both motor signals and sensory signals. If I cut right here, and I look at the front of the spinal nerve, right here, right at the very front, right? I'm gonna have both motor signals and sensory signals. So that is one big difference. So now we mix the motor and sensory signals, right? Then we split it apart again. So once we form the spinal nerve exits our back region and it turns into the dorsal ramus or the ventral ramus, right? The dorsal and the ventral rami, they are different than the dorsal and the ventral root, all right? The dorsal and the ventral root are very specific. Dorsal for sensory, ventral root for motor. But when we talk about the ramus is formed after we form the spinal nerve. So when we talk about the dorsal ramus, that contains both sensory signals and motor signals. The dorsal rami of all of our spinal nerves goes towards the back. As it goes towards the back, right, you'll have motor signals that move towards the back, and it allows you to contract your erector spinae muscles, right? Your iliocostalis, right? Your, muscles like that. Your spinalis, your longissimus muscles, right? All of those are activated by motor neurons that goes through the dorsal rami. Again, dorsal ramus formed after the spinal nerve. Because of that, they're mixed, sensory and motor. The ventral rami is what's really important here. The ventral rami here in the thoracic region turns into our intercostal nerves, right? That's not what's important. What's important is a couple things. Number one, right, in areas where we don't have ribs. So in areas where we don't have ribs, there's more room, right? So we have then a cluster of these ventral rami of our spinal nerve, and they network and fuse with other spinal nerves to form plexus. And that's what these plexus look like. So when we see the cervical plexus right here, the cervical plexus from C1, C2, C3, C4, C5, right? Those right here are all from only the ventral rami. The dorsal rami of C1 goes towards the back. The ventral ramus goes to the front, helps form the cervical plexus. Same thing with C2. So in C2, you have the ventral rami going out, fusing with branches from C1, helping also form the cervical plexus. It goes all the way down to C5, right? What do we see? In the cervical plexus, multiple levels of spinal nerves. Their ventral rami goes to the front, and then they connect with other levels of spinal nerve to form larger, more important nerves. So these plexus we're going to talk about are going to be caused by a mixing of signals, mixing of neurons, more specifically, mixing of axons of those neurons from different levels of the spinal cord. So from the C1 spinal nerve area of the spinal cord, what happens? The ventral rami exits, and it connects with other ventral rami from C1 and C2, from C3, right? From C4. So what happens is you have a mixing of signals, and it's going to help you form very important nerves. So the nerves I wanted you to know for the exam, phrenic, musculocutaneous, right? For the lab practical, all of those nerves, the median nerve for carpal tunnel, the sciatic nerve, right? All of those we can kind of, I talk about a lot because people have issues with those a lot. But all of those nerves are all formed not just from one spinal nerve that exits, right? So one spinal nerve, there isn't enough fibers to form that large sciatic nerve. In order to form that large nerve, you need multiple spinal nerves to cluster and network together, to share their axons. So then you can combine them all to form something larger, right? That's the thing of the cervical plexus. It's a sharing of signals from these different spinal nerves, so then we can form larger named nerves. Now, in terms of the cervical plexus, brachial plexus, lumbar plexus, sacral plexus. These are four I want you to know, and they're gonna form very important nerves that we're gonna talk about later on. The plexus are only from the ventral rami. So only from this part that goes in front, right? The one that goes dorsally, they do not form the actual plexus. So keep in mind that in areas here, right, where we do see ribs, there's not enough room for mixing of signals. So you don't see a thoracic plexus. Why? Because you have ribs, you have so much, viscera in the way, you can't form those networks, right? You can't form plexus then from T1 to L1. Notice that absence. There's 12 thoracic vertebrae, right? And that's the 12 thoracic vertebrae. Take a look. None of this in the middle do we see a thoracic plexus. Now, the communicating rami is part of our sympathetic chain of ganglia. What in the world does that mean? So let's take a look right here, right? We had mentioned on Monday that you had lateral horn cells. Lateral horn cells contains cell bodies of our autonomic motor neuron. So autonomic is the automatic, fight or flight, right? So what happens? If you are working out and you want your heart rate to increase, you want your blood pressure to slightly increase, you want your breathing rate to increase, all of that needs to increase. You want more blood flow to the muscles that you're working. What happens? Well, we need to somehow cause a heart to contract harder and with more speed. We need to speed it up so our heart rate increases. How do we do that? Especially if it's involuntary, right? We do that because of the hypothalamus, right? They send a signal down to the cells found at the lateral horn. So I'm going to come all the way back here to look at the spinal cord again. Whoops. Right here. Lateral horn, right? What happens? Well, the lateral horn, we have those motor neurons that are autonomic. And when this hypothalamus activates these neurons, the neurons have their somas, cell bodies, in the lateral horn. Then they have myelinated axons that exits out. Again, these are motor neurons, right? So all motor signals goes out through the ventral root. We're going to activate the heart. If we activate and increases the heart rate, that's motor, isn't it? It's not sensory. So what do? We send that information that's motor out through the ventral root, out through the spinal nerve. And unlike somatic motor neurons, you exit the spinal nerve and it goes immediately into the muscle as part of, right, your named nerves. Again, my biceps, as I'm doing bicep curls. The biceps is innervated by, right, the musculocutaneous nerve. So if I want to activate the biceps, I need the musculocutaneous nerve to fire. As it fires, it's going to release acetylcholine, and now I can activate the muscle. We have talked about what happens at that very, very end point where you release acetylcholine in chapter 9. Now we're talking about how it starts the rest of the semester here. It starts by activating cell bodies for my biceps on the ventral or anterior horn. Then an action potential goes through its axon, which helps form the ventral root. And then it exits out the spinal nerve. Then it goes down my brachial plexus, that nerve. Then it goes through the musculocutaneous nerve. And then it releases acetylcholine as it hits the biceps and the brachialis muscles. So when we talk about somatic motor neurons, it goes directly to the muscle as part of our named nerves. Kind of more complex with the autonomic, right? Here, we have a lateral horn cell. If I want my heart rate to increase, right, it doesn't go right to the heart immediately. It actually takes 2 neurons. And all we've seen is just one of it. So right here, we see the first neuron. The first neuron has its cell body in the lateral horn. It's got its axon that exits out, helping form the ventral root. Its axon then exits out the spinal nerve. And then it needs to make contact with the second neuron. So before, that was just the first neuron. Now, as it exits out through the ventral root, it needs to make contact with this, right? This is called the communicating rami. Some books call it the rami communicans. Why do we call it communicating? The reason why is simple. It's communicating between the spinal cord and the rest of your heart and your tissues. So if I want the heart to increase its heart rate, I have motor neurons. The first one has its cell body, the soma, in the lateral horn. It's an axon that exits out the front, the ventral root. It helps form the ventral root. And then it goes through the spinal nerve, goes through the rami communicans, where it connects with a second neuron, right? The second neuron has its cell body in what we call the sympathetic ganglia. Notice that these are bumpy, right? Why are these bumpy? Just like the dorsal root. Anytime you see the bump, there's a cell body here. So what we're gonna see in the sympathetic ganglia, it's bumpy because it's got cell bodies that we can activate. Then it has these cell bodies in the sympathetic ganglia, gets activated, and then it has an axon that goes directly to the heart. Again, in order to decrease heart rate, increase respiratory rate, increase blood pressure, we need to somehow increase the motor output of those areas. Unlike somatic motor neurons, these autonomic motor neurons requires 2 different neurons to be activated. In somatic, 1 neuron comes out, you just then goes right to the skeletal muscle. Pretty easy. In autonomic, the first cell body comes out through the ventral root, goes out through the rami communicans, synapses with a second cell body that is found as part of our sympathetic ganglia. Then the cell bodies that are part of sympathetic ganglia, those are the neurons that directly connects to the heart, that connects to the lungs. So then those neurons with their cell bodies here as part of the sympathetic ganglia, those neurons then directly activate the heart, increasing the heart rate, increasing the strength of contraction and blood pressure. So know what the communicating rami means. It allows you to communicate between the spinal cord and your fight or flight vessels. Right, so we talked about cervical plexus. I want you to highlight this area right here with the phrenic nerve. Why? Because the phrenic nerve is the single most important nerve we have in our body. You guys might have heard of the saying, C3, C4, C5 keeps you alive. The reason why is simple. All of these branches, C3, right, fuses with the, come down, right, C4 comes down, C5, right? What happens? From C3, the ventral rami, from the ventral rami of C4, ventral rami of C5, they all give fibers to form the phrenic nerve. The phrenic nerve innervates the diaphragm. Without the diaphragm, you don't breathe. This is a reason why when people get spinal cord trauma above C5, there's a really good chance that they will stop breathing. That is something that does happen. A few years ago, a football player, I believe he was only in the 2nd year. I say a few years ago, the longer I teach, the longer it was. So I believe it's like 5, 6, 7 years ago now. First play of the season, kickoff in football. He's playing for the Buffalo Bills. He runs down, wants to make a tackle, puts his head down. As he puts his head down, he makes a tackle, but he caused spinal cord trauma at C2. What happened? What happened was he couldn't move. He couldn't feel anything below the neck. More importantly, he stopped breathing on the way to the hospital. He would have died if they did not put a tube down his throat and allowed and intubated him so they can breathe by way of a ventilator. What happened with him was that it was amazing. There was a doctor there, a neurologist, that had just gone and been part of a convention where they discuss traumatic spinal cord injury. And as part of the convention, they talked about hypothermic therapy, cooling the body. And what he did was, the guy's gonna die. Worst case scenario is gonna die. At that point, best case scenario is he's gonna be paralyzed without sensation. So those are terrible worst and best case scenarios. So what happened? They give him very cold IV saline. They give him all right, and sounds terrible, but cold, right, enemas to cool his body temperature down from 99 degrees to 80 degrees. What happens is it prevented movement of inflammatory cells to the site of trauma. What happened with him was that he was paralyzed for the first week that he was in the ER, or he was in admitted into the hospital. But slowly, he started getting better. After a month, he was able to walk out of the hospital. All because by decreasing the body temperature, you decrease the flow of those inflammatory cells. And we found out that it is those inflammatory cells that goes to the site of injury that cause tremendous inflammation in the spinal cord. That's what usually causes permanent damage and permanent paralysis. If we can slow down the movement of those cells, yes, you might have that spinal cord, what we call spinal cord shock, but your body can heal. And if we stop the movement and that massive inflammation, hopefully we can kind of cause the severity to be lessened. For him, he still walks, right? He still has sensation. Obviously, he doesn't play football anymore. Now, brachial plexus comes from C5 to T1. Maybe in the future, if you're gonna go through like a advanced degree, you'll need to talk about posterior, all right, the middle cord, and then the lateral cords. But for us, we're not gonna discuss it too much detail, right? What I want you to know, the brachial plexus, is that they come from the ventral rami from C4 to T1. And they give rise to all of motor and sensory to your arm. So axillary, radial, musculocutaneous, ulnar, median, those are all nerves that are from the brachial plexus. Now, the axillary nerve, what do I want you to know for the next exam? What are the muscles it goes through? The deltoid, teres minor, right? Now, keep in mind, wherever you see the nerve, it will innervate and give motor signals to the muscles it's close to. At the same time, it also receives sensory signals from that same area. So if we innervate the deltoid, where's your deltoid? Upper shoulder. Kind of makes sense that you get sensory information from the outside of your upper shoulder too, right? Right here. Makes sense. Same thing with all of these. Radial nerve, posterior. What do I want you to know? Flexion of the elbow. No, better yet, not flexion, extension of the elbow, because it's posterior, right? So it's going to arise, come out, and it's going to allow us to have extension of the elbow, meaning it's going to innervate the triceps. And it's going to give rise to, as well, the region of the tricep and region of your, right, extensor muscles in your forearm. So take a look at this. If you know radial nerve is in the back, well, your posterior muscles are all extensors. Triceps is in the back of your arm, extensor carpi radialis, right, longus and brevis, supinator, extensor digitorum, extensor digiti minimi. All those muscles in the back, posterior compartment of our arm, all by the radial nerve, which is also posterior. All right, again, highlight this and then highlight these. I'm not gonna, all right, right here. Extends fingers, extends wrist, extends elbow. Also, sensory from the posterior upper arm. Kind of makes sense. Triceps, posterior upper arm, right? So kind of makes sense that you have sensations from that posterior upper arm carried in by the radial nerve. Same thing with the posterior lower arm as well. Musculocutaneous goes to only two main muscles. Well, three, but all right. And those are the flexors of your arm, your elbow, and your shoulder. Coracobrachialis, biceps brachialis. So anything with brachii in the front. is going to be musculocutaneous. And it's going to be important for flexion of elbow and shoulder. So just highlight that and this. I'm not going to ask you the muscles that it innervates. I do want you to know the movement and the region of skin. Next, ulnar. This is our funny bone when you hit it. From the medial cord, doesn't, right? And what we're going to see is that it's the ulnar nerve even way up here, right? Once you form it, it's called the ulnar nerve all the way down. It's going to allow us to activate the main flexors of our fingers. Musculocutaneous, flexion of the elbow and shoulder. Flexion of the fingers, flexor digitorum profundus, right? Well, those are going to be from the ulnar nerve. Flexus metacarpal joint, abduct and adduct fingers, flexus fingers, flexus wrist, right? So those are the important things about ulnar nerve. And because the ulna is pinky side, you can see that it makes sense that all the cutaneous sensations are on the pinky and, right, outer edge of our ring finger side. Median nerve, right down the middle. With a median nerve, we're going to see, with the median nerve, it goes right down the middle. So all the muscles down here, down the middle, right? Palmaris longus, pronator teres, and then the flexor carpis. So it also helps with flexion. Flexus fingers, flexus wrist. The big one is, it goes to pronator teres. So it also allows for pronation. Next big one, right? We've all heard of people that have carpal tunnel. The carpal tunnel is caused by, right, is formed by your carpal bones, your pisiform and your trapezium on each side right here, right? It forms a little tunnel underneath it. And then the median nerve goes right in between that tunnel. There's the flexor reticulinum, right, over here, that kind of acts like a wristband. And what happens is if you use that muscle of your fingers a lot, what occurs is that you can have inflammation here. If you have inflammation, there's no give in the flexor reticulum right here. And it can pinch the median nerve. That's carpal tunnel. So median nerve, in terms of sensations, index, middle, and part of the ring. Right? Again, flexion of the wrist, flexion of the fingers, the big one, pronation of the forearm and arm. Right. Now you can skip the rest of the brachial plexus. Lumbar and sacral plexus. Lumbar plexus between L1 and L4 and give rise to your obturator and femoral. So right here and right here. So this part right here is our lumbar plexus. Your sacral plexus is over here. Sacral plexus gives rise to our sciatic, which is a combination of our common fibular, common peroneal, and your tibial. So what happens is that in certain books, the sciatic is just kind of a combination of those two, right? Sometimes the book actually, right, even up here, just calls it common fibular and tibial. So just keep in mind that certain books and certain, websites might be a little bit different when we talk about the sciatic nerve. All right, obturator nerve goes towards the medial part of our leg. So think obturator goes medial. What muscles are medial? Adductor muscles, right? Your groin muscle. So it makes sense that obturator nerve supplies your groin muscles, allowing us here then to adduct our leg, right? Pull your legs together. We've all been in those, God, I hope we can get to the gym soon, but when you're at the gym, you sit down and there's a machine where you have to spread your legs and then slowly squeeze in. Those are working your adductor muscles, right? As part of that, you require the obturator nerve to stimulate it. It also receives sensory stimuli then from the medial upper thigh region. Femoral nerve, also from our lumbar plexus. The femoral nerve goes to the front anteriorly, and then it goes through that, what we call the femoral triangle right here, and then it splits into the saphenous, right? The femoral nerve goes to every single muscle in the front. So as it comes down, it's going to give rise to innervations to the psoas major, iliacus, therefore your iliopsoas as well, then your sartorius and your quadriceps. So the muscles that allows you to extend your legs and flex your hip. Iliopsoas muscle flexes the hip. Flexion of the hip is movement of your thigh bone, your femur, upwards. That is one of the functions of the femoral nerve then. The other function is to extend the knee because it goes to your quadriceps. Now, this femoral nerve is the main sensory nerve of your anterior leg. Take a look at that cutaneous sensations over here. So right here, if you take a look, it's huge amount of space, right? In your anterior upper and then anterior medial lower thigh, right? Lower leg, all as part of that sensation brought in by the femoral nerve. Now, the last one is sciatic. Sciatic is called the ischiatic as well, right? Sciatic is a combination of the tibial and the common fibular. So here's a tibial part right here coming down. The tibial part coming down comes down right at the area of your hamstrings. If it comes down your hamstrings, it's going to give muscle innervations to your hamstrings. Perfect. So one of the main job of the hamstring is to flex the knee. So highlight this area. These two is probably the best right here, highlight. Extends the hip, flexes the knee. Remember, tibial and femoral are on opposite sides. If you know femoral is for the quadriceps and the iliopsoas, femoral then is to flex the hip and extend the knee. Then the tibial, or part of the sciatic here, right? I'll say sciatic, not tibial, right? The sciatic here, right? The sciatic over here. So write down, cross this and say sciatic, right here, right? The sciatic then, so again, cross this out, tibial and put sciatic for now, right? The sciatic as it comes down superiorly is completely on the other side. It's an antagonist then of the femoral. So if you know one, hopefully you remember the other. So this goes to your hamstring muscles, including your semimembranosus, semitendinosus, right? Only the long head of the biceps femoris, which is weird, right? So those are your hamstring muscles, which allows you to flex the knee. Right? Now, it also allows us to extend the hip because it's the opposite movement than to the femoral. As we come all the way down, the tibial nerve splits into the medial and lateral plantar nerves way over here, which allows us to activate our muscles that are found in our foot. Your flexor digitorum brevis, your flexor hallucis brevis. Those are all part of the muscles of the foot, all part of the medial and lateral plantar nerve innervations, right? Again, write down sciatic here, right? Now, the sciatic nerve right here, and then over here with the flexion of the toes and flexion of the foot right here, right? I want you to write down, so just kind of highlight these areas right here. That will be from the tibial nerve, right? Again, I think I will probably repost this, right? With I'm going to repost it with exactly what I just mentioned, that up here until, right, you hit the knee, this is going to be the sciatic. Once you go below the knee, then we call it the tibial. Questions? I know it's kind of confusing, right? There's kind of an, all right, I don't know why I probably forgot to repost this one. So the tibial nerve starts over here. As the tibial nerve starts over here, down and around in the knee area, is going to be posterior lower leg, your calf muscles. So your gastrocnemius, your soleus, all of them allow us to, right, push off, plantar flex. Those are all then the function of our tibial nerve. Right? Then we have flexor hallucis longus, flexor digitorum longus, right? That allows us to flex our toes. So it also allows us for toe flexion as well. That's your tibial part of the sciatic nerve. The fibular part of the sciatic nerve comes down and around, right? And what happens? The fibular part allows us to innervate the biceps short head, as well as the peroneus longus and brevis for the superficial fibular nerve, and for the deep fibular nerve, tib, and your extensor digitorum muscles, longus and brevis over here. So in terms of the common fibular, I want you to know the common fibular splits into deep and superficial fibular nerve. And the deep one goes deep and innervates your muscles that are more medial. Anterior tibialis, extensor digitorum longus, extensor digitorum brevis. So the main purpose of these are to extend your foot, extend your toes. Now, we don't really think about extension when we talk about our foot. It's probably easier to know that you're bringing the foot upwards or dorsiflexing it. Think about what happens when you are walking. When you're walking, you push up with your toes, right? That's plantar flexion. As you land, right, you usually land with your heel, and then you rock and push off again. As you land, right, so when you push off, your heel is a little bit higher than your toes because you pushed off. In order to move your foot then upwards, you need these nerves right here, especially the deep fibular. The deep fibular allows our feet, our toe region, to move upwards. So then the heel is below the toe. Because the heel is below the toe, when we land with our body weight, we hit our heel first, and then the toes follow. So then you can push off again, right? What happens is when the deep peroneal or the deep fibular or even the common fibular and peroneal nerve gets damaged, we have a condition called foot drop, right? I'll kind of link up to YouTube to show you foot drop. But foot drop happens a lot in elderly people. And what happens is when they step up and plantar flex, they're able to walk and push off fine, but they can't, right, kind of invert it. So then their toes stay downwards and the heel stays up. And then when they land on their toes. And then with their body weight, they push the heel down. You can imagine it kind of really makes your balance terrible. And more people that are elderly with this are more prone to falls because of this. Right. Those are the ones I want you to know. That's it for this chapter. And I will repost some of this, right? I will repost this as well this afternoon. Trying to get this to end. I just wanted to show you guys one more thing. If I can get this to end. And here it is. All right. I'm just going to quit this. I want to show you the video right here. I'm going to show you the video in a second of just how soft our brain and spinal cord are. Yes, it's on YouTube, so it's okay. So here as we go on YouTube, and I do have it is from Utah.